May I invite Dr. Roy Patankar. We have an interesting session next coming up. Sir, stage is all yours.
Ladies and gentlemen, after opening carotids and aortas, now it's time for some non-surgical talk to whet your appetite before a sumptuous lunch that follows. Again, thanks to Kerala State Chapter for this opportunity. And in the next 30 minutes, madam, 30 minutes this time. Don't press the buzzer before that. So she's going to let me speak for 30 minutes on musings in the COVID era. I think all of us are on the treadmill of life, walking faster and faster. COVID gave me an opportunity to think about where I was and where I was going to in life. And this is particularly directed to the residents sitting at the back of the room who are talking right now, not paying attention to my lecture, but I think you need to. So smart people learn everything from everyone, average people from their experiences, but stupid people have all the answers. As a surgeon practicing in an academic or a non-academic situation, you are in a tussle between surgical skills, acquiring them, speed, the race against time, effort to cope with increasing numbers of patients you do in practice, technology, legal demands, and ethical dilemmas. So to progress, you need three things: knowledge, skills, and competence, which most academic programs and teaching hospitals will give you. So this lecture will be a little beyond what you need to acquire to be successful in life. This is a chart which happens to most surgeons. And we see a good amount of surgeons will learn what they do in residency, do a couple of years of senior residency, AP, and practice with the same skills throughout their life. And that is a zone of mediocrity. What I learned from residency, I will do forever. What you need to do is go into the passion barrier to enjoy the tough cases. And these are patients who are referred to you from other peers and complicated patients. Upgrading yourself. Choose the right technique. This is a famous management slide from a municipality in Peru which built a bridge without realizing that the river was changing course. This is sort of a autobiographical lecture. I made many mistakes. I learned notes. I learned single incision laparoscopic surgery, spent a lot of time, money, energy doing on pigs and patients, not realizing that this really wasn't a technology that was going to stay. So this is upgrade yourself in the right way. All of us pass through 3-4 zones. I think the first zone when we come out of fellowship or out of residency is the comfort zone where we think we've acquired all the skills we need to practice in life. To learn a new thing, be it robotics, be it thoracoscopy, be it advanced labs, you have a fear zone. You feel, I'm in private practice, I can't handle morbidity, I have no time, I have a big list to finish, my juniors will not get trained in opens. These are common things I hear from across the country where I travel to teach. But only 20% of the surgeons throughout their life will go through a learning zone and a growth zone. I want you to understand this concept of circle of competence. And giving my own example, I'm fairly competent at doing lap colorectal surgery. I do a very good anterior resection, colectomy. But if you ask me, I can't do a Whipple's like Jimmy John. I'm not as good as that. But I probably think I'm a very good laparoscopic pancreatobiliary surgeon when I'm not. So how to overcome this hurdle? Be honest to yourself. Define the perimeter of your circle of competence. Slow down. Work to expand the circle, and don't fool yourself thinking that you're God's gift to laparoscopic surgery. You aren't. Read and learn from other people's mistakes. Whenever you start a new procedure, again, these are my experiences of doing anti-reflux surgery. I started doing fundoplications in 1995. We have now done more than 1,000 fundoplications. With some gray hair or no hair, you realize some problems that you have faced. When you came out of fellowship in the United Kingdom, I thought I had assisted and done about 25. I knew it all. All patients would get a Nissan's fundoplication, all would do well. Then I started getting the gas bloat, a little bit of dysphagia, some RAP migration, and you think, I'm never going to understand this. And gradually with time, it starts to make sense, and you realize that in a functional surgery like a rectal prolapse or a pelvic floor dysfunction or an anti-reflux surgery, choosing the right operation for the right patient is as important as technical details. Never be fixated on the outcome. Beware of information overload. You attend many meetings, you hear many things, you read many things. Be very, very careful that you don't get overloaded with that. We have 5 fellows post-MS who join my department every year, and they want to learn how to do lap oncology, lap anti-reflux, thoracoscopy. But Believe me, ladies and gentlemen, you need a lot more than technical skills and confidence to become a good surgeon. You need judgment, you need to build a great team, you need self-care, and you need, more importantly, mentorship and humility. I think all of us surgeons have large egos. You know, my boss in England would tell me there are 3 kinds of surgeons. They call me God, I want them to call me God, and then finally God calls me God. So we all have degrees of ego which we need to remember. I think if you want to progress in life, you need to have humility and not hubris. This is a wonderful paper in 2019 in JAMA Surgery called Joy Toolbox, Optimizing Joy in Surgery. To be a good surgeon, quote unquote, be grateful, be a good leader, be a teacher, be intentional, accept coaching. I think coaching is a concept alien to the Indian surgeon. Cultivate compassion, remain involved in the community, and look for humor in life. Laugh at yourself, an important trait that we need to cultivate. For the youngsters in the back, whatever you are not changing, you are choosing. Read that again and think about what I'm saying. When I was fresh out of MS, just had spent 3 years as a lecturer in Mumbai, the career paths can widely diverge. You remain in government service, go into private practice, go abroad, do a fellowship. So a surgeon's growth path often depends on whether he chooses the avenue of soothing applause or the trail of prickly criticism. I chose to do functional surgery apart from oncosurgery. I chose anti-reflux, achalasia, pelvic floor disorders, incontinence, not very fashionable area. I said this morning, these are Cinderella topics. I think do an anti-resection or a Whipples is fashionable, it earns you more money. But choose a topic of interest. Build your brand, and you will get work from across the country and internationally once you become good at that. A lot of talk now is about burnouts. I think if you look at Western data, almost 20 to 25% of surgeons complain of burnout by the time they are 50. Looking back at my own life, I think we are all jugglers with 3 balls. One ball you throw up is your professional life. The second ball is your personal life, the time you give your family and your relatives. And the third ball is your social commitment to society in general. It is almost inevitable that when you throw one ball higher in the air, the other 2 balls remain lower. So TME is not total mesorectal excision, it is time, money, and energy. When you are young and fit like you are at the bottom, you have a lot of time, you have a lot of energy, but little money. You come to a stage in life, the front rows, you have very little time, lots of money, but very little energy to spend that time. So important that you prioritize this and understand the concept of enough. Don't look at social media. This is what social media typically is. You'll always see the lovely apple, but not looking at the back. Don't compare your chapter 1 to someone's chapter 20. If Dr. Santosh John Abraham has reached the pinnacles of what he is today, it is after 25, 30, 40 years of hard work. So don't expect to buy a Mercedes or Audi in the 3rd year and buy a fancy bungalow in the 5th year. There is a struggle that you need to do. And behind every successful man, there is a struggle. Need to understand that. There is a difference, ladies and gentlemen, between complacency and contentment. I think spirituality, rationality, philosophy will teach you contentment, but never ever become complacent. Remain professionally discontent all your life. And this is for the residents at the back. Every year you must acquire a new skill. A time will come when you can't spend the money that you're earning, but at least remain professionally discontent to learn one new operation, one new concept. It can be E-TEP, it can be robotics, it can be third space endoscopy, but every year learn one new skill in life and you will never go wrong. I know in Kerala you have some great mentors. I've met some fantastic teachers since morning, but you need a mentor in life to progress. I've been fortunate to work with these people, Dr. Srikhande, Dr. Palnivelu, Dr. Bhanushali, and believe me, I have never actually directly worked with any of them. This you can say is distance learning. I've attended every laparosurgeon in Coimbatore. I've spent enough time with Dr. Bhanushali, Dr. GV. I go once a year to AIG in Hyderabad just to see what new is happening there, and this is important. This is a paper fresh off the presses, March of 2023. If you look at professional sportsmen, it is important that every sportsman, a good, successful sportsman, has a coach. So why can't you as a surgeon not have a coach? To have a sustainable performance, ladies and gentlemen, you need coaching, you need feedback, you need preparation, and you need recuperation. The problem is when you're head of department like I am, you're usually surrounded by residents and fellows who generally will not criticize you. They will not blame your decision making. If there's a leak, the leak has happened despite your skill. So surround yourself with people who will often be critical of you, and for this you need a mentor or a coach. I have two people in my department, Dr. Avinash Supe and Dr. S.K. Mathur, who both of my teachers are both working full-time in my department. I think the most important thing I learned from them is a course correction. You need someone like that to tell you are going wrong, you need to change course before you go wrong. So I often feel that ease in acquiring anything, in acquiring skill, acquiring money, acquiring reputation, is often a greater threat to progress than hardship. If you work hard for the money, for the reputation, for acquiring skill, you will naturally value that much more. This is very important for where modern science is taking us. There are people who are skeptical of new evidence, who will not try any new procedure. Third space endoscopy is rubbish, ETEP is rubbish, robotics has no role in India, we are a poor country. There are people who are hawkish, that every new technique is the greatest thing in sliced white bread. What you really want to be is remain in the center. Audit your own data. Look at what's happening world over. I am now convinced robotics is here to stay, even in a third world country like India. We acquired a robot 3 months ago. I'm learning robotics. So remain in the center. I was not the first to buy a robot. I looked very carefully, spent time in Korea and Singapore, in other centers of India, convinced myself that robotics is here to stay, and then I will fit my business model to robotics. Science comes first. Then to see how financially and business-wise you can do that. All of us are biased. We all have our pet biases, whether it is thyroid or breast or whatever, we are drowning in information. We generally seek out information that confirms your belief. And I'm going to give you my own example. I was a great believer in the star operation. Those few of you who were there in the morning, I said the star operation I started doing in 2013. We did 200 surgeries, and at the end of 5 years, we realized that our success rate was only 60%. So before that, whenever I read a paper, if it didn't agree that star was good, it must be a bad study. I would spend 2 hours on that paper reading material methods, statistics. It must be a wrong study, it has flaws. If it said star was good, then obviously it must be a good study. I would read that paper in 10 minutes. So this is how surgeons are biased, whether it is third space endoscopy or a Heller's myotomy or robotics. Be very careful. Remember, ladies and gentlemen, better surgeons know that surgery is more cerebral than technical. You can learn technical surgery on YouTube by watching people. But that's where you need to work in a good academic department with a good mentor, and you'll understand the surgery is more in the brain than in the hands. Diseases should not be adapted to technique, but technique to disease. When I learned stapler hemorrhoidectomies, I started doing PPHs in every piles that came to me. When you have a new hammer, every problem is like a nail. I then realized there are problems with a PPH. As I tell my fellows, you need to know every available tool. Every available tool in the armamentarium should be there and fit the appropriate tool to the appropriate patient. This is a famous management principle called Texas sharpshooter fallacy. Look at what this guy is doing. He's firing his gun and then drawing a circle around where he is fired. This is what I mean by bias among surgeons. We get biased because we are looking for data that fits into our preconceived beliefs, which is often not true. Some things that I tell my fellows who work with me. Number one, sepsis is not an antibiotic deficiency syndrome. Every Whipple's doesn't need tazobactam and meropenem. I would still use basic cephalosporin, sulbactam, or even cefotaxime. Number two, drains don't compensate for bad technique. Dr. Udwadia, who I worked with for a brief period, would tell me the best post-operative care you do is what you do on table. Post-operative CRP is higher antibiotics, monitoring is secondary. Spend that 10-minute extra, do the anastomosis right, be principally sound in what you do. There is something called the Sod's law of anastomotic leaks. If on table you're doubtful about anastomosis, if it's 50-50, 99% it will leak. Redo the anastomosis, use ICG, check vascularity, but redo the anastomosis if you're in doubt. If there's a 50-50 chance of getting something wrong, 90% it will go wrong. So drains and antibiotics don't compensate for errors. We are habitual, casual theorists. Remember, if you are post-op Whipples or a post-op lap chole at 48 hours is distended, has a tachycardia, you do ultrasound, you think yourself, I'd let some saline in the abdomen, that's why seeing fluid. It isn't. Look at the patient clinically. This is where getting another senior surgeon to see a post-op patient is important. We generally tend to avoid re-exploring our own patients easily. We believe, God willing, all will be all right. But optimism kills the patient. Hope is not a strategy. For the young middle grade surgeon like Jimmy, surgery is a small community. Don't burn your bridges. To be successful, you need humility, not hubris. And the last 2 slides are on ethics. Now, I'm a medical entrepreneur. I own 2 hospitals with a total of 250 beds. I employ about 500 people. So for me, top line and bottom line is important. Science is important, but somebody needs to pay my EMI. So whether you like it or not, our profession has become a business, and we are in the professional marketplace. We have consumer ethics governing us. These are extremely important things, and I'll end by saying this, that become rigid about ethics. There's nothing, I always keep telling my managers that good medicine can be good business, but good business can never be good medicine. Remember that. If you remain focused on patient care, you can never go wrong. And I'll read one of my favorite poems from Peter Winbrow Sr. called The Man in the Glass. When you get what you want in your struggle for self, and the world makes you king for a day, just go to the mirror and look at yourself and see what that man has to say. For it isn't your mother or father or wife whose judgment upon you must pass. The fellow whose verdict counts most in your life is the one staring back from the glass. He's the fellow to please, never mind all the rest, for he's with you clear to the end, and you've passed your difficult, most dangerous test if the man in the glass is your friend. You may fool the whole world down the pathway of years and get pats on the back as you pass, but your final reward will be heartache and tears if you cheated the man in the glass. Thank you very much. Ten minutes before time, ma'am.
Thank you, sir. Congratulations on a very emotional talk. Ladies and gentlemen, now it's the turn of our National President, Dr. Sanjay Kumar Jain. May I invite you, sir. It's an honor for us. Yes.
Hi. Roy sir, please come. Thank you for accepting our invitation and for the wonderful presentation. I invite Dr. Jonas Kurian sir, our former HOD and professor, to hand over the gift pack and also our Punnada. Thank you, sir.